afternoon, everybody. I'm thankful for the Global Exchange Forum to have given me an opportunity to talk to you about our collaboration. As I'm going to operate the slides manually, I will be going there. Is that okay? During my talk, I'm going to talk about collaboration as well as a little bit about Sri Lanka. So to begin with, I'll be talking about Sri Lanka for a few minutes. Sri Lanka is a small country. It's less than half the size of North Carolina, and population is, of course, more than 2.5 times the North Carolina population. And we are located 6 degrees above the equator, so there's hardly any seasonal variation. Most of the time we are having summer, so that's comforting to know when we feel cold here. So having said that, obviously the population density is high, and of course infrastructure is much less developed than in United States. I'm going to make comparison with United States so that you get some idea about how to assess Sri Lanka from many points of view, from points of view of health and otherwise. Part of India is always shown in the Sri Lankan map because people ask, where's Sri Lanka? So, no idea is, and as you see, we are an island, and Galle, where medical school is located, is in the southern tip, and our main campus is 30 miles further south along the coastline, near in that dent you see near the circle, and trying to pull out my, where's the point? Sorry. Another one, here is one. I don't know where I kept my one. Start putting it in my pocket. Ah, yes, it is here. Sorry. Okay, I'm all right. Thank you. Yeah, it is here. The parent one is here, and so in Galle we have 2 of the faculties, engineering and medical, but they are separated by about 2 miles, and the medical faculty is about 3 miles away from the city. And the country was affected by civil war for 30 years, and most of the eastern and northern parts of the country were not accessible during those 3 years freely, and as you see, about 2/3 of the coastline was involved during the war, and northern points, eastern points, all those had limited access to the general public. But what good news is that in 2009 May the war was over, and exceptionally we have been able to get rid of a terrorist war which has not happened anywhere else in the world. So thanks to the present government, country is enjoying peace and things are getting much better than what it used to be. I'm telling this because once I remember there are 5 students graduate students from Duke who were ready to come, but suddenly a bomb exploded in Colombo and their parents said nothing doing, and the State Department advised them not to go. So now things are different, so it's taken a better turn. As for when you come by you land here in Negombo, that's where the airport is. It's about 20 miles north of the capital, Colombo. We don't have highways or freeways, so you need to cut across the capital, get stuck in traffic for about maybe 1 hour from the airport to the capital, Colombo, which is a commercial capital. This is the administrative capital, which is just on the outskirts of Colombo. To come from the airport to the city takes about half an hour to 45 minutes, depending on the time of the day. If you come in the night, then you're okay. Otherwise, there's a lot of traffic. You've got to come through the normal thoroughfare. Coming from Colombo to Galle, it takes about 2.5 to 3 hours. In the middle of the night, if you come, you can come in 2 hours. And from Galle to Matra, where the main campus is, it takes about 1 hour. It's a nice drive along the seaside. And in Matra main campus, there are 4 faculties. That's science, marine science and technology, arts and social sciences and humanities, and finance and management. We have another faculty which is towards the interior, somewhere here, and that's agriculture faculty. These are few shots from Galle, and Galle has this historic Dutch fort which is about 300 years old. It has been built by 3 colonizing nations, starting with Portuguese, then Dutch. Most of the work was done by Dutch, and then British. So we got independence in 1947, and so we really follow British kind of work, as English is the main foreign language that is used in the country. It's all influence of the British colony we had for about 75 years. Now, so this is a landmark. This is at night, and this is during daytime, and this is an aerial view of that, and this is the fortress. This is a very I like this path because every morning I walk here. It's about 1 mile, and you can see the sea. Right? So these are pictures that are taken, and this is a picture I took at about 6 o'clock in the morning when I do my morning walk. It's the lighthouse, which still works, but people are not using it because of radar. It's available now. So Galle is picturesque if you want to visit Galle. Some of you have already visited, also they know what it is like. Coming back to some facts, we are somewhat unique in the sense that we provide health facilities and education totally free. But of course, those who want the option of paying for their medicines can certainly go to a private medical institution. Same thing applies for education. People want to get paid education. There are private education institutions also. But education from primary to tertiary is all free. Of course, when it comes to tertiary education, it is limited because it's comparative to getting the universities. I'm going to talk about it a little later. As you see, there are 70,000 beds. Little over 10% is private. Most of the hospital beds are in the government sector, and there are over 1,000 primary care centers managed by general practitioners. Now these are not government oriented or government sponsored ones. They are totally private, and there are no regulatory mechanisms other than the fact that the doctors are having the license to practice. But side by side you get Ayurvedic practitioners, which are native practitioners, and there are homeopathics, and there are quacks also. Right? We have our quota of quacks. So it's a mixed population, but considering the region of South Asia, we have very good health statistics. I'm going to address about it a little bit a little later. Doctor population is 10,000. These are qualified doctors, right? Not Ayurvedic doctors or the others I mentioned. And in the region, these good statistics are 2,400. But of course, compared to US statistics, we are well below. Nurses, again, some point approximately 7 to 8 per 10,000 population. And then midwives are not many. When it comes to dentists, pharmacists, numbers are low, but pharmacists are having a very good time because drug sales are not regulated. Like corner shops, you get pharmacies anywhere. You can buy any medicine over the counter, right? If you know the pharmacist. And the pharmacist is not there most of the time. Only his license is hung up on the wall. He is employing young people to dispense medicines. So that's happening. But people go to doctors. Of course, they are not just self-medicating. When it comes to physiotherapists, medical lab technicians, occupational therapists, speech therapists, numbers are very few. Speech therapists, less than maybe 20 in the country. So some paramedical services are not developed at all. We started a few paramedical degree programs: nursing, medical laboratory technology, physiotherapy, and radiography. All that we started recently in different universities, but their output is yet to come because it's a 4-year degree program. We spent this much on health and this much on education. We used to spend about 20% on the war. Right? It's quite a lot, but now I think it's less. But the government is not cutting down a lot because they want to be very defensive to see that these terrorists won't come back. So they have fortified themselves in the north and the east. So that takes a lot of money from the country budget. Not much of a difference between Sri Lankan life expectancy and US life expectancy, despite all the drawbacks I mentioned. I don't know why. Infant mortality. Actually, we are very good with regards to our health statistics. If you take, say, Pakistan, it's about 66. India, it's about 48. So our figures are very low compared to some of the most of the countries. In fact, in the Indian software, in our software. When it comes to doctors, the doctors in the US, I guess they are all specialists. When you consider from our norms point of view, because our basic degree is a bachelor's degree, medicine and surgery. So amongst this 11,000, you get about 1,500 specialists who may be comparable to the US doctors from the point of view of services they are doing. Of course, at a different level of technology. Well, this is the roadway to become a doctor and a specialist in Sri Lanka. And as far as primary and secondary education is concerned, the time spent is approximated same. But our students don't have to do 2 degrees to become a doctor. They do a primary degree only, and that's 5 years duration, and that is what we are involved in our medical school. After 5 years, they get the degree which is called MBBS, Bachelor of Medicine and Bachelor of Surgery, and they are not entitled to practice medicine unless they do a compulsory training period of 1 year. That's what we call internship. So it may be a bit like residency, but very much up and down compared to residency, like first year resident there. When it comes to specialization, they have to sit for a screening exam depending on the specialty they want to study, and it's highly selective, very competitive, and they end up in the program. And the program, of course, varies from 5 to 8 years depending on the specialty. Specialties like cardiology, neurosurgery, as long as 8 years, but specialties like internal medicine, general surgery are not that long, 5 to 6 years. So if you look at the age of doctor, in that sense our doctors come out a little younger than the doctors in the US because of the fact that they come out partly trained, not as specialists. That's the reason. So with all these avenues, what I want to say is that the entry to medical program is very competitive, right? And it's only 1% of the birth cohort that gets into the university. 100 people are born today, only one will get into the university. All universities are government universities and they are non-fee-levying. There are 8 medical schools. 3 of the medical schools are in and around Colombo. One is Colombo Medical School, which is older. It's about 140 years old now. And our medical school is only 33 years old. And there are some medical schools even younger than our medical school. So selection to medical school depends on the General Certificate of Education Advanced Level exam, and that is a highly competitive exam where they have to offer biology, chemistry and physics, and they take the top 1,200. Of course, not a straightforward thing. I don't want to go into details. I'm going to talk about collaboration, so I need time to talk about collaboration. So maybe somebody can ask any questions if they need to know exact mechanism of selection later on. Okay, this is the beginning to the collaboration. When I was the dean, Truls contacted me and wanted to talk about the collaboration. It was a very traumatic event for us. I was on call on that day. It was a Sunday, post-Christmas or Boxing Day. It's a double holiday, fortunately, because there were no schools. It was anyway end of the year vacation for school children. Schools were there. We would have had many more deaths. I was on call, but my wife called me and said, "Look, there's water coming along the canal. We live by the side of the canal." Then looked out, and so that's something I never seen. But I read about tsunami, but the word didn't come. But I knew that sea was coming. So we hurriedly exited the home, the car. We were the last to leave, and we came back in 2 hours' time. About a foot of water had come into the house and gone off, doing a lot of damage. The perimeter wall was damaged and gate was in pieces, right? So it was a very traumatic event. Fortunately, none of our family members or close relatives died, but I knew some of my friends died, and including 10 alumni. All 10 are my students. They have got caught on the way when they were traveling along the coastline, because it's a weekend holiday. They are going along with some of their families. One student who came looking for a hostel to enter the medical school, the following year, January, we were starting, it was December 26th, she lost her life, and one student hostel was totally damaged. Fortunately, no students were there when it happened. You might wonder what this train is. This train was a train that left a place called Ambalangoda, which is a small town about 30 miles north of Galle, where the medical school is. On its way to Galle, it had to stop because water was coming. About 3 feet of water came, train stopped, and villagers also got in. And that was 9 o'clock, the first wave came. When the second wave, which was about 15 feet, came, the train toppled and it got submerged in water with 1,500 people, 1,500 people in it. So this is the world's worst train disaster. Few escaped through these windows because you were lying on its side, and many bodies were found inside, and people not allowed to get anywhere closer because you it was like they were sort of entombed basically in this. So later on only they have turned it upright again. So this was on a stride because what happened when the second wave came, the railway track got washed off and it lost its balance. People who sought refuge from the village, in addition to the people who were already traveling, got drowned. Yeah, so this is the beginning of the collaboration, and then of course about 5 years old we looked, I think all of us looked little younger and more hair. We had more hair in our heads. So it was set up a conference call. Professor Merson was there, Professor Corey, and Cynthia was there. Yes, and Rose and Chris Wood, and we were having chat for more than 1.5 hours, and then you all thought it was useful to come and visit us, so we visited a few weeks later, and several months later we signed the agreement, and the link came to place. Right. Now at this point I want to go through the aims and objectives of our collaboration. Maybe there are some few things that I left out. Basically there are two aspects. One is collaborative research and the other is academic development. So there are a few things I'm going to address later, so I won't go through it now. But lab staff was trained, right? Dr. Ariyananda is here. He trained some of our lab staff at GenTech in Kalam, and some more training was done. And we also reinforced our lab facilities under the link. We did few research projects. So institutional development in the way of human resource strengthening as well as acquisition of equipment was carried out. So many things were done. We have a little office in the faculty. We have full-time coordinator. We have had changing heads over the last 5 years, the different coordinators. So currently we have the third proper coordinator. Then when we have a research project, we hire pre-interns, that's doctors with MBBS who are waiting to start their internship, and data entry operators as and when research demand is necessary. I believe the budget comes from DGHI and HYC. Okay, correct me if I'm wrong. Then we of course get the blessing from the Dean's office and Finance office and collaborators, and the program runs. So this attendance list, I don't know whether anybody is missing. It's about I got the full list. Okay. Okay. Now I am here. Right. You might wonder what I am doing here. As was said, I came with some support from Duke because Fulbright Foundation found it attractive to get somebody who has already worked with Americans to come, because their vision is to get people to come to America from non-American countries, to establish good links and take things back home so that we can do collaborative research and collaborative academic projects. So I had done some already, so I was on a better footing, and we in fact hosted the senior Fulbright scholar in our faculty during my tenure as the dean, so that helped. And having come here, I want to look at the curricula of various programs, and Sarah Trent is helping me a lot, but I have not started it on a big way. Looking forward to do it. And the process, I really don't want to go through the content, I want to go through the process. So in the having an idea to study the process means I need to look at some documents and also sit with what's in the teaching environment and see what's going on. Actually, I've been following some residents and fellows in the Duke Hospital already last week, and also I'm shadowing many consultants in the pulmonology department. That has helped me, and I need to meet people and find out whether we can start up on some other research collaborations. This is our main campus that I already mentioned to you. It's a nice campus, spaced out, picturesque, just a stone's throw away from the sea. So you can actually, when you go to the heights, you can see the sea from there. It's a nice view. This is the administrative building of our faculty. We have an auditorium here. Can accommodate 1,000 people. It's a air-conditioned good auditorium. But we don't have routine lectures there. This is located just across the road from the hospital. So it's good for students who come here. That's a short walk. I don't want to go through this slide because it's a busy slide, but this tells us that we are having a traditional didactic subject-based curriculum. There's a lot of room for improvement. So we have a 5-year program with these subjects, and the medium of instruction is totally in English, and we take 140 students every year. So at one given time we have about 700 students in the faculty. Continuing on the program, our inputs comes as clinicians here. We mainly give our inputs in the final year, but they do clinicals from the end of second year onwards. Okay, now this might be of some interest for Duke students, because this appointment, which starts in the third year, is carried over to the final year where the pediatric appointment is, and they do research project. It's compulsory, and they have to visit the community. So we used to call community medicine public health earlier, but now for some reason the name has been changed to community medicine. This is Neela Goswami. She is the first of the 2 residents who came. So these are some of our medical students. They are all clad in saris. It's in a community medical center. They're just posing in front. These are patients who are going in and out. In fact, I met Neela last week. They're quite happy. This is a hospital. This is the outpatient department. It's a busy hospital. This facility was opened just 1 week ago. It's a new emergency trauma center, and these are 2 wards, female and male. They are open wards. There are no cubicles. The walls are half or 3/4 walls, so that there is ventilation across. As I said, their nights are not cold, so people are happy to live with this. It's nice and cool in the night. Daytime it may be a bit hot, and we notice there are mosquito nets. We have to protect patients with mosquito nets. Mosquitoes are there all the time of the year. That's one thing I miss in America. No mosquitoes. Now, a little bit about the hospital. So this is one of the teaching hospitals. Each medical school is affiliated to a teaching hospital in Sri Lanka, and Colombo, of course, has many affiliated hospitals. So it's a large hospital, 1,600 beds, but as you saw, the beds are close by. They are like dormitories. They're not individual cubicles, so therefore we can afford to have many beds. So square area per bed is less, and of course doors are open all the time. Anytime, day or night, patient wants to come and take treatment, they can come. They say request admission. First, the doctor who is in the admission area says no. Patient may or may not go if the patient is very insisting. They get admitted anyway. So that's because non-fee living, and also this, although this 1,100 beds are there, we can have 2,000 patients at one given time. Where do they sleep? Between beds, under beds sometimes. Well, this is a situation with our health system. But they are all looked after. Whether they are on a bed or otherwise, they are all looked after well. And when it comes to documentation, all the documentation is done in English, and doctors, medical students are conversant in English, and the nurses can understand basic English. So for students who come from Duke, residents who come from Duke, they always are at ease. Although only a limited number of patients can speak in English, but most can understand English. But they are always assisted by our medical students and doctors so that they can navigate their way. When it comes to history taking, there may be few patients who are good in English. Some of them are quite good. So with such patients, Duke residents are well at ease, but others, they have to get the translation help from the medical students or the doctors. So why go to Sri Lanka all the way? Well, we have some differences, as I been mentioning from the beginning. We see a different spectrum of diseases, so-called tropical medical problems, in addition to our bread and butter is like here, diabetes, hypertension, asthma, ischemic heart disease. Majority of patients have that problem, and also malignancies. And of course, they present late. It's not always the case, but you get the late presenters, right? Who you might wonder why late. They go to other practitioners. Some of them don't. The communication is also not good. They listen to others. They try out various remedies. Even a cancer, breast cancer, they might detect a nodule, might go to an Ayurvedic practitioner, or not just disclose it. That's again a cultural problem. Some of these patients don't like to disclose their problems in their breast. They're not educated to do self-examination of breast, so that they can get advanced cancer and then they can come late for treatment. So that's one of the reasons. Of course, when they come late, they have gross physical signs, good for the students, both the graduate, PA students and residents to see, and they also can come with various multiple pathologies. So complex cases and complicated cases, because interference in the community by other practitioners like quacks can cause, we see quite a few cases of septic abortion. It's not criminally intended, but there are some abortionists who are not qualified, who are quacks, and then they come, and unfortunately some of them are septicemic by the time they come, and the toll is high. When residents and PA students and graduate students come, they can see how we manage patients in low resource setting. Our ITU, there are very few ITUs, and we don't spend much for ITU, because our priorities are different. I think we have more to prevent, and as I mentioned, the influence of Ayurvedic medicine or any other medicine is there. I'll illustrate with some few examples. Oops, sorry. Yeah. Now, this is a patient with a fractured neck of left femur. You can see this right neck of femur is fine. The other one has got shortened, united. What's the end result? Short leg. This is not uncommon. Until few years ago, we were not putting pins for the hip fractures. So they were on traction for months on end, and therefore lots of patients used to go to native practitioners. They end up with a big limp, although they can walk, but not the big. So of course now, as you know, after a couple of days they can be out of bed after a pin. So this is just one example. Another example is here, collar fracture. See the deformity. This does not illustrate the true dinner fork type of deformity, but it's because I've taken it at a different angle. These are all pictures taken by me. All my patients, although I'm a physician, the fracture neck of femur guy came to see me for some other reason, but I just took the opportunity to take pictures. So this is again deformed hand following native treatment. If the patient had come for reduction, this kind of thing would not have happened with modern medicine. Lymphatic filariasis is very common in Sri Lanka. And see the size of this leg. This is the normal leg. The filarial worm goes and the larvae go and occlude the worm as well as the larvae occlude these lymphatic channels, and then there's collection of lymph, and it gives rise to swelling and fibrosis, and these are not reversible, and this is a common finding, and they get recurrent attacks of cellulitis due to this bad foot hygiene, leg hygiene. Yeah, this is a close-up of it's called elephantiasis because so when you come to Sri Lanka, you see lots of elephants. There are elephants on the road, right? The tamed elephants. And you go to a sanctuary, you can see about 50 elephants without exaggeration. We have plenty of elephants. This is called elephantiasis because the skin gets so thick and it's like the hide of the elephant. It's all due to lymphatic obstruction. Nothing much can be done about it other than keep once it happens. And so you can see this kind of feet around. This is a patient who, again one of my patients, came with foot deformity, leg deformity following childhood rickets. Right? So they get all sorts of deformities like so-called varus deformities, valgus deformities, like bow legs, knock knees, and this is another one, bone bending, right? Because bone becomes very osteomalacia, bone becomes very very flexible. Goiter, see the goiter just coming out. I don't know whether you can see this kind of thing in US, but these are people who don't want to get treatment at the outset. Most of these are due to iodine deficiency. They are quite happy to be with it, and many such advanced, some of the surgeons don't want such also because of tracheal collapse and later airway problems. Very advanced hypothyroidism. This is the mother, one of my patients. They were living in a very remote place with no access to motor vehicles, and this child has she's 28 years. She was, and I took the picture. She had not gone to school, and her mental age was around 3 or 4. She had not grown, but we started on thyroxine, but it was too late for her to catch up with her growth. But because she was very cheerful, this is after starting on thyroxine. She was much more different before we started on thyroxine. Okay, now clinical material, as I said, there is a different array. You see snake bite. In fact, Guinness record book had Sri Lanka rated as the highest snake bite country some time ago. Right? So don't worry, they are in the wilderness, so somebody wants to come to Sri Lanka, don't, as you step down from the plane, you don't get snakes, so don't worry. Poisoning is another problem. Agrochemicals. We don't have very good psychiatric services. So as a result, depression can go undetected up to a point when some people try to commit suicide. They are in the rural agricultural community, what's at hand is pesticides, weedicides, which are very toxic, and paraquat. If you take about 5 to 10 ml, it's enough to kill. So it's too late when they realize after taking it, and many die. Right? It's not the story with paracetamol. We also have our share of paracetamol overdose, but none of them die. But here with paraquat, 5 to 10 ml is enough. Organophosphate is another weedicide. Plant poisons. These are nice looking flowering plants in the wilderness, but people take this and they die. Yellow oleander has cardiac glycoside, which can cause heart block and very high mortality. We see this type of patients every day. Yellow oleander poison in paraquat. Now, to Karapiti Hospital, we get about, when I say every day, about 4 or 5 cases of paraquat per month, about 2 or 2 deaths. Out of those, 50% mortality. This accidental burn due to kerosene oil, bottle lamps, which are not protected. When the lamp toppers, the whole house catches fire. That's it. Sometimes whole families, but I seen when I was a medical student, I was doing casualty, and I saw mother and 3 children admitted with kerosene, bottle lamp burns, and all 4 of them died. Few days later, of course, due to infection and dehydration. Yeah, a few slides about snake bite. I hope it. Yeah. Well, we have all these fellows, right? But in the wilderness, right? If you leave them alone, nothing happens. But how we get involved is, as doctors, we see people from the agricultural community coming to us with snake bite. Yeah, this kind of thing that we see, they have got a swollen leg. I don't know if you can see the blisters. There's a blister here, small blisters. Can't see the bite marks because they are so tiny. A guy who can't open the eyes because some of the snake venoms are neurotoxic, so they paralyze muscles. Can open the eyes. These are all my patients. Yeah. Now, oral cancer is another thing that we see. Right? Although smoking is not so common, but chewing beetle. You might wonder what beetle is. Not the insect, but this is the this is the leaf, right? With the you can see there. What people do is they use dried tobacco leaf, lime. Lime is the powder. It's calcium something. Not the lime fruit, right? So it's a powder, but it's like people apply on their walls also lime, like a whitewash. They put a bit of that and also a hard nut which is crushed. All these things have stimulants and that's what they use for to keep awake. So they, like drinking coffee, they will chew the mix. Some of them have a nasty habit of going to sleep with that in the mouth. So the contact time with the mucous membrane is very long, and that can cause metaplasia, cancer later. Like what now? See, this man has a lot of beetle stays in his mouth. His teeth are stayed, and you get angular stomatitis due to the irritant effect. So this is this whitening is leukoplakia. And then what happens later? It's not the same patient, but both. I've seen both patients for various reasons. See, advanced cancer. By this time, secondary lymphatic spread also may have occurred. So, Buccal cancer is very common in Sri Lanka. So is esophageal cancer. Despite low smoking rates, infections, there are many. Leprosy we still see, but not in epidemic proportions occasionally. See them? Leptospirosis will be very common. These are subconjunctival hemorrhages you see in these patients, and some of them are jaundice. I think there is a tinge of jaundice, but you can't see it on this slide. We are talking about HIV. News is good. We don't have many HIV cases compared to India, our neighbor. I think it is partly due to cultural reasons, and also India is such a vast country, and it said that in India infection is carried by these truck drivers who have contact with prostitutes on the way from one state to the other. In our case, I think education is also better. Now, for example, I mentioned that men are 99% literate in Sri Lanka compared to 75% literacy in India, and women 92% literate compared to 47% literacy in India. So there is a big difference in the literacy also. I think it matters. So that may be also some contributing to a lower HIV status. My figures are from the CIF fact book. You know, this verified on the internet. So good news is so far we have had approximately 100 deaths. 1,000 deaths, and so there is no sort of room for alarm. Accidental burns can occur due to firecrackers and all sorts of things. The patient who has had a vapor lamp bursting and burning all his body, these are old scars. And plastic surgery is not widely available, so they can't get the disfigurations corrected. See, this child is studying with a bottle lamp. It can topple any time and catch fire. Yeah, so it's a risk. And there was a global campaign done by one of our surgeons who has managed to develop a safe bottle lamp. Even if it topples, the kerosene doesn't come out and catch fire. That's available in the internet, that information. If you go to Safe Kerosene Project of Sri Lanka, it's quite accepted worldwide. In Africa also it has been adopted. Hand injury is also common. Okay, when you go there, you find this king coconut, yellow coconut-like nut. It has a nice sap in it, and people are happy to, serve you. The vendors will come behind you offering. And this guy, this one of my patients, he came for some other ailment, but what they do is, they just cut it and give it to you so that you can get it off the nut straight away. Right? He has been too distracted, so he's chopped his fingers also, right, during the process. These are careless hand injuries. You see this kind of thing also. Firecrackers, instead of some people like with a cigarette, and instead of throwing the cracker away, throw the cigarette away. See what happens, right? So poisoning, I already mentioned, corrosive poisoning. In rubber industry, they use formic acid, and it's a corrosive, so with suicidal intent they take. See what? I don't know whether you can see that very well. A lot of burns on the face, but the esophagus gets burned. After that, they end up with dysphagia. They really become miserable and get emaciated over time. Some of them don't die and suffer. Others, of course, die when they take a large amount. So you see what the tarapot does? It does pulmonary damage. Patient dies of acute respiratory failure. But this is a very distinctive appearance of the tongue, which appears after about 3 or 4 days after ingesting tarapot. Rather pathognomonic. Yeah, we'll see what the residents can do. Well, when they come, they have to get registration with the medical council under 67A so that they can practice. So when Duke residents have been handling our patients, doing procedures. Right? They teach medical students. They take part in ward rounds, clinics, journal clubs, brand rounds, peer group discussions. In our unit, the first two, that's Neela and Robbie Goswami, they started the evidence-based medicine discussions. So I'm happy to say that it's now going on. This is something initiated by Duke students, right? Because they can get involved in research and of course leisure. These are the people who have already visited us. I haven't put down the names of the 3 graduate students. We've got 2 PA students and we had 1 MSc student and another one is already there. So quite a reasonable number, but we hope more students and residents will come in time to come. There are plenty of things to see. Yeah, I've got only a few more slides, so I'll be finishing in time. Then the graduate students also can do a similar thing. So are PA students. Okay, these are good things, right? Yeah, this again, thanks to digital age, when I go to Colombo, I stop and take these pictures by the wayside, because these, the Colombo Gold Road is a coastal road. Yeah, this is a fish net. People are just, what they do is they go to the middle of the sea and then lay the net, and then they draw the net from the coast, and the net finally sort of traps all the fish. So these people are pulling, I don't know whether you can see it, at the right end of the picture there are many people, they are pulling on a rope, and at the other end is a net. Paddy fields in the agricultural part of the community, that's where people come to hospital after taking paraquat and organ phosphate. But the country itself is beautiful. We are very famous for tea. I hope you are drinking Ceylon tea. We were known as Ceylon before 1972, although it's called Sri Lanka now. We have the best tea. And also some companies, they buy our tea and mix it and then sell us some other country tea. So go for original Ceylon tea. When it comes to arrival, there are few things that they have to do. Advise them to look at the website. Application form is there, but you cannot fill it online. You have to take a printout and then fill it manually and submit it. You can send a scanned picture and follow it up with a mail copy to be on the safe side, so that you know that you are registered. Visa at the airport, 100 per month. So straight away I can give 1 month visa. Similar thing. The difference is residents will have to apply for registration with the Sri Lanka Medical Association. That for 3 months they charge 2,500 rupees, which is about $25 US. Right. So coming back to Duke-Ruhuna link program, what have we done? We have done several studies as listed here, and there are a few publications and communications, and also data which is resourceful. There are some things which are planned. There is potential for comparative studies, I think, because we from parallel studies are going somewhere else. We can do, replicate those studies in Sri Lanka. See, when in a different socio-cultural economic setting, whether the figures are different, facts are different. Well, outside the medical school and the hospital, you can extend your exposure to these some of these organizations. There are others also where you may be able to involve in socio-economic research or medical research as well. And it's good for non-medical students from Duke we met after coming. This is my wife, and this Robbie and Neela Goswami, and this is Dr. Bapan. They have all been with us as residents last year. So there one other resident which we could not get. We met last week and they took us out for dinner. So this taken at a cafe. Melissa Briggs was on call, so she could not come. I think that's about it. So this is the summary of my talk, and this is an island. Actually, you can rent out the entire island. I'm not joking. It's between the main campus and Gaul, halfway between. You have seen this? Yeah, it's available. I won't tell the price. Not maybe to some of you. I have been to this place, but not to stay. But I know it's an old house. Is there about 3 rooms? And when the tide is low, you can walk to the mainland. Right? High tide, you'll have to swim if you want to go. As you see, there are steps here. So it's available for rent. It's not a Sri Lankan who is owning it. I think it's an Italian. Yes. So that's about it. Thank you very much for being here.